Welcome to the March Virtual Journal Club, everyone. Really excited to be discussing this topic today. So today we're going to be defining the dimensions of diversity to promote inclusion in the digital era of healthcare. Before we get started, some quick housekeeping notes. Today's session is being recorded. You can access the slides from DIME's websites. We also want to hear from you. So we've dedicated some time for Q&A. And you can raise your hand and I will invite you to share your question live, or you can type it in the chat and one of us will ask it. So those of you who have attended DIME events are familiar with this slide. I've included it here today to emphasize the role DIME plays in promoting inclusivity. DIME sits at the intersection of healthcare and technology, two communities who play critical roles in the success of digital medicine. These communities also represent the stakeholders who stand to benefit from the digitization of healthcare, and both have a big role to play in achieving health equity. As both of these communities look to achieving health equity, DIME is setting the guardrails to ensure that inclusivity is the foundation with which we transform healthcare and research. Representation is critical to promoting inclusion. Communication and education resources generated by DIME are open source and available to all stakeholders. Our research and resource development reflect the priorities that are critical to advancing healthcare and research. And our community includes experts from across tech and healthcare. They represent all the stakeholders who stand to benefit from digital innovation, including patients. These are the people who can take the actions that we need to transform healthcare and research to help achieve health equity. How and what we talk about is also very important for promoting inclusion and achieving health equity. For today's discussion, these are some of the definitions we will be using. Diversity, equity, and inclusion are often stated as DE&I, as if they're one thing. They are three different elements that each need careful consideration. So diversity is the differences that contribute to our individual identities. Equity refers to justice and fairness that should transcend diversity. Inclusion is ensuring that all are welcomed and can fully participate. Our conversation today is inspired by health equity, the state in which we all have a fair opportunity to attain our highest level of health. And we're talking about digital medicine. So digital equity and digital inclusion add that layer of ensuring that information and communication technologies are available to everyone. Okay, so now that we have those fundamentals in place, let's get to the fun part. My name is Yashoda Sharma. I am a program director here at DIME, and I am leading our efforts to expand DIME's health equity portfolio. Sorry. I apologize. I apologize for that. Always great timing. I am honored and excited to be your moderator today. Today, I'm joined by subject matter experts with very different perspectives, and all are vital to achieving health equity. Let's start with introductions. So we'll go in the order that we have on the slide. So Annie, then Amy, then Michael, and Jen. Annie, please introduce yourself.
Hi, everyone. Thanks for having me. I'm Annie Saha. I'm Associate Director for Strategic Initiatives at the Digital Health Center of Excellence at FDA. I am a proud member of the liaison to the Data CC, that DIME runs. And, a lot of our efforts, of course, at FDA and in digital health are how can we ensure that patients have access to high quality digital health innovations in a timely manner, and that we're also promoting efforts to not exacerbate the digital divide, but really get technology to everybody.
Thank you, Amy.
Sure. Hi, I'm Amy Schoen. Thanks again for having me, and to all of you for being here. I've had a career that's focused on public health and health equity, starting with working on HIV prevention trials at NIH, and most recently directing an initiative at Case Western Reserve University School of Medicine, where I developed health applications for public health practice. I became gravely concerned about the risk of digital medicine exacerbating health disparities. And when I started getting calls a few months into the pandemic from health systems wondering how to get their most vulnerable patients to use telehealth, I left the university and have been doing digital health equity consulting full time. One of those calls was from the National Digital Inclusion Alliance, who asked me to represent them, sharing my expertise on digital inclusion to the DIME Data CC project that gave rise to the lexicon that we're discussing today.
Great. Welcome, Amy. Michael?
Good morning, everyone. Thank you for having me this morning. My name is Michael Crawford. I am the AVP for Strategy and Innovation at Howard University's Office of Health Affairs. I'm also the founder and executive director of Howard University's 1867 Health Innovations Project, which is our digital health innovation program designed to collaborate with researchers, entrepreneurs, technologists, corporate partners to enhance adoption and access to digital health solutions for vulnerable and medically underserved communities. I'm also the founder and executive producer of 21st Century Health Podcast, which is a podcast that focuses on topics at the intersection of digital health, health data, and health equity. I have spent my 2 decades in healthcare, working throughout the ecosystem with an express mission to ensure that we are providing the highest quality healthcare through various means to all populations, regardless of all the things that we talked about today from an equity perspective. So it's a pleasure to be here. I'm looking forward to the dialogue.
Great. Thank you, Michael. Jen?
Good morning, good afternoon, everyone. Jen Goldsack, CEO here at the Digital Medicine Society, or DIME. And I'm really delighted to be with you all this morning talking about this topic, especially alongside colleagues on the line. So much of what we're going to talk about today is actually part of the origin story of DIME. When we were thinking about, how do we make sure that we actually capture the full promise of the digitization of healthcare, which is creating a healthcare system that works for everyone. Diversity, equity, and inclusion, Yashoda, just as you articulated them, have to be at the forefront. It has been the cornerstone of our work. Yashoda, I want to recognize the leadership that you have here at DIME and making sure that it is infused in everything we do. It was terrific to work with you and Annie on the paper that sort of promulgated this particular discussion. And Amy and Michael, you've been sort of colleagues, peers, advisors, friends in this for a long time now. So I'm just excited to be here. And Yashoda, thank you.
Thank you, Jen. So I gave you a quick glimpse into partnerships and representation, and I'd like to talk a little bit more about that. So one thing that I have learned during my time at DIME is that partnerships are vital to doing work that will be impactful. And so Jen, I'd love to start with you. Multi-stakeholder partnerships are one of DIME's superpowers. Our inclusivity work started with one of those partnerships, Data CC. So please share with us how Data CC started on this path and how that has evolved for DIME's health equity work.
Happy to. So to sort of unwind some of the acronym soup here, Data CC is it's a hard one acronym, so I'll let you see if you can scribble this down and figure it out, is the Digital Health Measurement Collaborative Community. And so all of our focus on how do we actually redefine health and disease? How do we measure, monitor, predict how healthy someone is outside the walls of the clinic. All of that work at DIME falls under our Data CC portfolio. We are delighted that that is a collaborative community with official FDA participation, and we couldn't ask for someone better than Annie to be sort of that liaison, that champion for this work. And I think what's really important to note is that the work that we did on diversity, equity, and inclusion was the first body of work that we did under Data CC. I think that underscores the importance of bringing a community together to really champion an inclusive approach to the digitization of healthcare, and in particular, how we define, measure, monitor health and disease in the digital era. We cannot sit here and make decisions for someone else about what good data elements look like. We need diverse, representative patient insights into this. Amy, you are such an important champion of that work. We now have our own patient in residence here at DIME, Grace Cordovano, who is a powerhouse and keeps us sort of honest on all of this stuff. But here's what's particularly interesting, and I think important for the purposes of our conversation today, which is too many times at the moment, I find myself in conversations where there seems to be a level of contentment with going after tip of the spear innovation that only works for the few, with the assumption that this, the promise, the success will then trickle down to other populations that our industry exists to serve. And there's an example that I like to give that reminds us that that is not how this industry works. And we can think about the first time that insulin was given to a little boy with type 1 diabetes was now 101 years ago. It happened he was starving to death in a hospital in Toronto, and 101 years later, the United States is still under a human rights watch because insulin is so expensive, because 1 in 4 Americans with diabetes ration insulin. We do not go back and make sure that health innovations work for everyone. We never have, and we never will. We have to be comfortable with that. We have to bring people together. And the importance of this work is to say, we are going to build it intentionally to work for everyone from the beginning. And the inclusion framework that I know that Yashoda, you will sort of brief folks on at some point today, is really to keep us honest. If we can't actually say, are we building it for everyone? Can we measure that? Can we assess it? Then we're only fooling ourselves and doing a great disservice to the promise of the digitization of healthcare and all of the patients that we are here to serve.
Thank you, Jen. Let's turn to Annie. Annie, we are touching on 2 CDRH priorities here. First, pre-competitive collaborative communities, but definitely health equity. How are you positioning these to address challenges and opportunities at the intersection of diversity, equity, and inclusion and digital medicine?
Yeah, I think it's a great question. And there's a lot of efforts being done, I would say, across the agency. So not even just specific to CDRH, for how we can support sort of inclusive digital measurement. And so collaborative communities are one important piece. And, Jen did a great job sort of highlighting the Data CC and sort of its use and ability to sort of move the needle forward. Because I think one of the things that we all recognize is that it's not one constituent or one group that can move the needle on digital measurement and getting, patients access. Like, it has to be a multi-lateral approach with different aspects, including different stakeholders, to really come together to advance both the science aspects as well as sort of the implementation piece. And health equity is a big importance, really, in thinking about one of our big areas that we're sort of prioritizing is the idea of moving health from the clinic into the home or to where people are. And so that's really where digital health and digital health technologies can really play an incredibly impactful role of really getting to people where they are, especially if you're talking about rural and other underserved communities who may not have the same access to, say, an academic medical center as maybe some urban populations, not even all in that case. And so where digital health can actually improve people's health and get to where people are instead of just getting to those few who have the access and the means. And that's really, I think, an important piece of where bringing together different groups of people to think through the problem as a whole, and not just, here's a regulatory fix. If we put out a guidance, that's not going to solve getting, access to people. And so we really need to think holistically across the board of what does it take from everything from a regulatory policy perspective to telecommunications, access, broadband, all of those things have to fit together for us to really improve health equity. And, we at CDRH and FDA are, committed to being part of the solution.
Great, thank you, Annie. I'd like to explore that digital piece a bit more. So digital is offering opportunity to increase access to care and the potential to mitigate health disparities. However, there's also a risk of widening the gaps. But before we can begin to address these, we need to make sure we know what we're talking about. And so, Michael, I'd love to turn to you. As we explore the perceived versus real opportunities for advancing health equity with digital tools, what are some foundational concepts we should be aware of to move from talking about it to actually taking meaningful action?
Well, thank you for the question. And I'm going to amplify some of the things that were just discussed. And one, I think we need to start with language, right? How are we describing and framing the problem? So I am so elated that you started this presentation with defining what DEI means, what health equity means, what does digital equity mean, what does digital inclusion mean? Because often we use these terms interchangeably. And when some folks are describing DEI, they think they're describing health equity. And then when some individuals are describing health equity, they think they're describing DEI. And there are different frameworks and constructs that need to be spoken to individually. They're self-reinforcing and complementary, but they're different in terms of how they impact the overall equation of healthcare, fair and just healthcare delivery for all. So when I think about how do we move from perceived to real opportunities, it starts with language. And then it also starts with an understanding and recognition that we have a trust and credibility problem that was exacerbated through the COVID-19 pandemic. We saw that as evidenced by testing and vaccine uptake. So I think that we entered the pandemic with this notion of perceived trust and left the pandemic with the notion that we need to move to more of a posture and perspective around earned trust. And I think that's where we're at now in terms of how we are looking and framing health equity, that through credible and trustworthy partnerships, we need to earn individuals, communities, and populations' trust in order for us to develop digital technological solutions that can advance individuals' ability to manage and optimize their healthcare. The other piece that I'll just talk about very briefly is when I think about the opportunity, and I like to frame it because so much of what we've talked about recently has been COVID-19 and how that has been a catalyst for so many initiatives that we're talking about today. Prior to COVID, we had healthcare disparities and social determinants of health. Those problems existed for decades. It's not new. They've been here. Those problems still exist. If you probably look at the data over the past 2 decades in terms of healthcare disparities, and I'll use maternal, child, and infant care, that data hasn't changed very much over the past 2 decades. One of my colleagues is an obstetrician gynecologist, and he talks about this constantly. The problem hasn't changed. So I think that we are now moving into this new era of 21st century healthcare where we're talking about the digitization of medicine. I think we need to become more solution oriented and move from conversation, data gathering, data synthesization, and mining to moving to how do we come to a posture and a perspective of action and impact. So, and I think that a number of those discussions are occurring today. One thing that I'm extremely optimistic about is per a recent Ernst & Young survey of over 500 health equity leaders across the provider, payer, life science, and biotech, government and nonprofit, and community-based organizations. that occurred this past year, 73 of those respondents suspected increase in prioritization of health equity, but the overwhelming sentiment from those leaders was that we need to move from conversation to action. And the only way we can move from conversation to action is if we really commit to having a comprehensive and cogent strategic health equity plan. And all stakeholders, I believe, need to have a health equity plan. Embedded in that health equity plan needs to be a DEI plan, because organizations that have a comprehensive DEI plan will be best positioned to be able to impact health equity at multiple levels. And because of the audience that we're talking to today, in order for you to be able to have that comprehensive plan, you need to have a data and analytics infrastructure that allows you to support said plan. And if you're able to do that, have that type of infrastructure, which is costly, then you are able to have some level of impact, measurement, oversight, and monitoring. The challenge here is that organizations with considerable resources, over $5 billion, do not have a challenge with allocating those types of dollars to building out a plan and an infrastructure to be able to impact health equity. The challenge will become in the future is how do those smaller organizations that are below 500 million in terms of revenue have the resources to be able to develop a plan and data infrastructure to be able to impact health equity. So that will pose a challenge. And we know that a number of those organizations that are below 500 million are closest to the community and underserved and that require those resources. So if they do not have the resources to be able to do that, we will continue to have a challenge in impact. The last point that I'll make is that we need to double down on the trust component. And that starts with, and I'm glad that Jen mentions that, and Dime does a good job of engaging stakeholders across the ecosystem. That needs to continue to happen in a very transparent, credible, equitable way in which stakeholders are providing input into how we achieve and realize some of the true goals and aspirations around health equity. And look at how we impact these things. And that comes with developing some relationships with community-based organizations, community leaders, individuals that have influence within different communities to make sure that their voices are being heard when we're developing initiatives, programs, and digital solutions that will help impact the overall health and well-being of all communities.
Thank you, Michael. There was so much in what you said. We can have 20 discussions on that one answer alone, and so many different projects. My brain's already starting to think of what Dime can do there. But I think you set us up really nicely with language does matter, and it is key to credibility. And that is kind of the basis for the lexicon that we've created. But I want to add, before we get to that, I want to add one more piece to the puzzle with digital. And so, Amy, I'd like to turn to you. Being connected to the internet is increasingly important for access to care and for using patient-facing technology. How do we optimize the impact of health technology on health equity?
So there are a few main strategies to think about. The first is to recognize that the goalposts for what it means to be connected have really moved. And in fact, federal law, the Digital Equity Act of 2021, actually codified into law that to be equitably connected, people need all of the pillars of digital inclusion, which is a device that meets their personal individual needs as opposed to shared across their household. They need a robust and affordable internet connection. They also need not just applications that meet their needs, but something that really gets left out a lot is tech support and training. And the training and tech support that are provided have to be sensitive to the digital inclusion barriers that people face, many of which are idiosyncratic to the different population groups that people are in. And part of that, a big part of that traces back to redlining and the segregation of minorities and low-income households into neighborhoods where the internet didn't come, or high-speed, affordable internet has not been available. So people living in those neighborhoods didn't have devices and didn't develop the skill set over 2 decades that other people have had. So and of course people need foundational skills. There's no point in trying to train somebody how to use a digital device until they have all of those foundational pieces of digital inclusion. Many low-income households may share a single flip phone or smartphone, and that's not good for apps that are continuously measuring, or a shared phone across a family is not good for ensuring that their data stays private. Now, another strategy, of course, is to make sure that apps and products meet the needs of vulnerable people, such as being in their language. But I'll just give you an anecdote. My partner, who is a retired health IT professional, was prescribed a continuous glucose monitor, and he found that it would not run on his Android phone. I was able to find him an iPhone 8 that my daughter had, kind of discarded years ago. And even with his IT skills, he was not able to update the software to run a phone that had been sitting there shut off for years without my help, because he had no familiarity with iOS. And then it took several hours for me to convince him to even get an Apple ID, so that we could get that whole ball rolling to get the phone updated, et cetera. So I had to wonder, had he called the device company, what they would have told him, and would they have been able to refer him to organizations that might have helped him get a device that would have met his needs. So you were talking about community partnerships, and people don't think about there are now 1,500 digital inclusion organizations across the country. And these are the kind of groups that I really try to connect the digital health world with, and digital medicine, because they can provide those skills. And then finally, I think we need to recognize that many digital health tools are not connected to healthcare. Continuous glucose monitoring is a perfect example, because people can now get it without a prescription. And so that, of course, is going to just reinforce equity challenges, because access is going to depend on being able to pay the full cost of something like that out of pocket, because you're not getting it through your doctor and through insurance. And people have some good reasons that they might not want to do that through their doctor. So those are a few strategies that are, I think, a little bit from a out of the box perspective.
Great. Thank you, Amy. Thank you to all our speakers who've really set the foundation and given us a nice broad overview of where we are now and what needs to be done. But I'd like to take a look at some statistics. Humans are complex and diverse. Health disparities are also complex and are a result of, as we've heard, decades of historical injustices and systemic racism. The lower life expectancy of those identifying as African American or Black is just one example based on race. But we know it's not that simple. Those identifying as Black men have an even lower life expectancy than those identifying as Black women. So now we're talking about race and sex. But let's look at another example. Those living in rural areas have higher prevalence of certain diseases compared to those living in urban settings. So now we've added geography. And let's add another component, educational attainment. So some studies have shown that increased years of education are associated with lower Alzheimer's risk. So these are some of the examples of the dimensions of diversity that significantly affect healthcare. So this is exactly why we developed the dimensions of diversity lexicon, specifically to draw attention to these factors and highlight their importance for promoting inclusion and for driving health equity. The lexicon acknowledges that health disparities are based on demographics, so we definitely need to pay attention to age, race, sex. But we also know that social determinants of health are major contributors. So geography, educational attainment, socioeconomic status. And we're talking about the digitization of medicine. So we have to pay attention to the digital divide. You know, as Amy mentioned, digital literacy, digital access are pivotal for medicine today. Cultural awareness. So, for example, language, cultural practices. These are also important influencers on how people experience healthcare. The lexicon acknowledges that multiple dimensions of diversity result in our individual identities, and each of these elements need to be factored in as we talk about healthcare, as we talk about being more inclusive with healthcare, and as we work towards achieving health equity. So now I'd like to turn to our panelists to explore the dimensions and the potential a little bit broader. Annie, we continue to hear that we need to do better for underrepresented populations, and people want to see themselves represented. Regulations and policies will play a key role in supporting inclusivity and driving health equity. As you plan initiatives for the Digital Center of Excellence, how are you approaching inclusivity and equity concerns, especially within the context of defining excellence for digital medicine? How can the lexicon inform your strategies?
That's a great question. I think, ultimately it really needs to be embedded everywhere. So it's not just where it really should be part of everything that we're doing. And so some of our activities are, include, of course, building on a lot of the work that we've done across the agency in terms of thinking about and hopefully final guidance on diversity action plans. And then our work in using digital health technologies for data acquisition and clinical investigations, and really thinking about getting to people where they are, key piece of that. And, Amy's examples really highlight this, is doing usability studies, thinking about human factors as a key piece of, can people actually use the technology? Are they having challenges with connectivity? How does that digital health technology actually work in sort of their day-to-day life? Are they able to actually use it? And that's really a key point that, we're really thinking about in how do you get to different and partnering with different organizations who can work with individuals and trusted individuals, because it's really about meeting people where they are, also with people that they trust and communities that they're engaging with to really move things forward. And, another key area that we're really thinking about, especially in the AI space, is thinking about transparency. And so the lexicon can also fit with that, of like understanding how these digital health technologies are performing in different patient populations, of being more transparent about, where the data, where, say, an algorithm was tested and trained in what patient populations, to better understand how those technologies do work for people. And goes back to like, how does it work for someone like me? And so being able to have more information out there for people, whether you're a provider or a patient, to be able to understand whether the technology has been tested, trained, can work to support someone in their sort of healthcare. And these are, just a snippet of some of the areas that we're really thinking about, and where the lexicon can support thinking about these different aspects and of diversity and demographics, and that understanding also that there is that interplay that you just talked about. You showed it. It's not just race, ethnicity, age. It's really if there's social determinants of health, and we have to think about and unpack all of those pieces together, and not just think about things in a one-off type of one demographic or another.
Yeah, exactly, Annie. And I think you've set me up really nicely for my next question with Amy, because I know she's done quite a bit of work here. Amy, last year you published a report calling for more collaboration between the health sector and digital equity organizations. Where are you seeing progress and opportunities? And I think you'll probably touch on a few of the things Annie mentioned as well. We'd love to hear a little bit more about this. And then where does the lexicon fit in with that?
Sure. So I just dropped a link in the chat to the report that you're referring to. And the report identified several digital inclusion strategies to improve digital health equity. But even since then, almost a year ago, several opportunities have emerged that could dramatically accelerate progress. In January 2024, CMS mandated that Medicare Advantage plans identify and address digital health literacy gaps among all enrollees. And CMS also approved reimbursement codes for certified community health workers who could do this digital readiness assessment and refer people to these 1,500 community-based organizations where trained digital navigators can help get people online and then help people use digital technology. Many of these organizations specialize in addressing the unique technology barriers that are specific to the population groups that are identified in the lexicon, such as people who identify as LGBTQ or with disabilities. A huge opportunity is that every state recently developed plans to spend that state's share of the $65 billion federal broadband funding that was appropriated in the 2021 Infrastructure and Jobs Act. And that includes $2.75 billion specific to digital equity. These plans all address what the feds call covered population groups, which are very parallel to the groups identified in the lexicon. Now, by and large, the health and technology sectors were not involved in the planning process that states just went through to say how they were going to spend all this money. And several of the states' plans got sent back to them because they did not adequately link with the health sector. So this is happening right now. And, you know, the feds are kind of begging the health sector to come to the table. So one of the plans, you know, things that could be budgeted for is training community health workers to do digital health navigation, or helping community-based digital navigators become certified community health workers so that their efforts can be eligible for insurance reimbursement. And then finally, I want to note that patient portals could have a significant equity impact because they are available free to every patient. They work on iOS and Android. They can address every health condition that there is, and they are the gateway to a lot, increasingly the gateway to digital medicine technology, a place you can upload your data and get prescribed, you know, products and learn about them. But again, people who have low digital skills, low-end devices, limited data plans, have barriers that are unique to the lexicon's population groups. They need to be trained to work as co-designers, including advising on how to incorporate technology into clinical workflows, including with training and tech support. So, you know, in some ways, I'm very optimistic and excited about, you know, these opportunities that there's never been money for before.
Yes, that seems to be the source of everything, right? The money, the finances. But I want to continue on this investment path here and turn to Michael with a different kind of investment that you're doing with the 1867 Health Innovations Accelerator Program. and with educating the next generation of health professionals at Howard University, how are you approaching the intersectionality of the dimensions of diversity as you consider digital health solutions to improve healthcare delivery?
Well, Amy touched on a number of things that I'll touch on that we're working on. But I just want to amplify the $2.7 billion investment in digital equity needs to be taken seriously by everyone on this call. So if whatever state you're in, try to contact your sometimes it's called a telecommunications office or whatever office that you may have to try to get involved in that. This is a real opportunity to really have impact. At Howard, I founded 1867 Health Innovations Project in 2020 with the express mission to advance the use and adoption of digital health technology in medically underserved communities. And keep in mind, this was pre-pandemic, right? So we were thinking about this prior to the pandemic when folks were, and this was when technology and telemedicine had low adoption at the time, right? So and now telemedicine has ramped up significantly and is a large portion, a significant portion of how folks are delivering healthcare today. And we really looked at the ecosystem and did a market scan. And what we found in the market that there wasn't a lot of centers of excellence in the marketplace that was focused on advancing digital health solutions for medically underserved and vulnerable communities. Some folks were doing it in a very siloed manner, or they were doing it, they had a therapeutic specific mission, but no one was looking at the totality of the challenge. And then what we also know that there was low data and research on digital health use in medically underserved communities, and there still is today. There's just not a lot of data about how medically underserved and vulnerable populations are leveraging technology. With all of that information, we decided to establish 1867 Health Innovations Project to do three things. Really to look at ways in which we can test and validate technology within medically underserved and vulnerable populations. Secondly, we looked at how we could become a thought leader and amplify the dialogue and the narrative around the intersection of digital health and health data and health equity. And we have done that through a forum called Digital Health X in collaboration with the Consumer Technology Association, McDermott and Will, in terms of convening thought leaders to discuss some of the foundational issues of creating a more digitally inclusive ecosystem to deliver healthcare for all communities. And then the other piece is how do we focus on the workforce, our students as well as alumni and faculty, to have them more acclimated with digital health solutions so that they can deploy them to the target population. So I'll talk a little bit about each of those buckets, and I know we're running short on time and we want to get to Q&A. But from a data validation, we run and conduct a number of digital health pilot projects, largely in areas of chronic disease management, because those are the areas that disproportionately impact our patient population, as well as the country at large. We're really focused on diabetes, hypertension, cardiovascular disease, cancer, and neurological disorders, and mental health. And recently, we've really been working in the area of diabetes to source digital health solutions that we can use and pilot with our diabetes population. We have a diabetes center of excellence. So we work very closely with our endocrinology team and look at how can we create a pilot project for our diabetes population to introduce digital health tools, medical apps, virtual augmented and mixed reality solutions, AI solutions, and data analytics platforms that can aggregate or disaggregate information and provide more insight to patients and providers. And one of those solutions that we recently used, and I won't name the partner and the companies because I don't want to just overtly promote them on this platform, but we've used, it's kind of an Alexa that dispenses medication that has facial recognition capabilities. And we were struggling, our patient population was struggling with medication adherence, and we know the implications associated with medication adherence and diabetes and the downstream impacts in terms of cost and health outcomes. So we said, how can we use this solution to help bend the cost curve and help improve outcomes? So we looked at creating a pilot project. We sourced that technology, the Alexa that dispenses medication, identified patients, put together a pilot project. In short, we wanted to do 3 things in that pilot project: improve the overall management of hemoglobin A1C levels among this patient population, improve medication adherence, and quality of life factors. The patient population was largely digitally naive. So that means that they haven't used technology in their life to be able to manage their care. And then secondly, some of the patients that wanted to participate didn't meet the inclusion criteria because of all the things that Amy just mentioned. Didn't have the skill sets, didn't have adequate broadband, didn't have a cell phone, a data plan, all those things. In short, the folks that did participate loved the technology. It improved medication adherence, management of diabetes, quality of life factors, and it was a population that never used technology before. We got great big data on the technology. We looked to scale that project to other members, and all the folks that participated that never used technology highly recommended this technology to family members and friends. So patients benefited because they were introduced to a technology by a credible partner. We had students working on the project. They worked with an innovation technology that now they're familiar with, and they would recommend and prescribe to patients moving forward. And then we had data and research that we could publish to help the ecosystem better understand the need for technology within this population. And we're trying to do that across different therapeutic areas at scale. So we love to work with Andy and the FDA to figure out how we could do that at scale, these validation and clinical pilot projects. And then the last piece I'll mention is around thought leadership. What we are doing with Digital Health X is really convening thought leaders on an annual basis to have a dialogue about what I believe to be some of the critical elements to creating a more digitally inclusive society, which is value-based care. I think value-based care provides an incredible opportunity to be able to leverage technology. Data, security, and privacy are critical elements now. In this era of cybersecurity attacks, we just had a major cybersecurity attack that impacted the entire healthcare ecosystem that has impacted trust amongst our provider and patient community. So we still need to work on that element. The venture capital and private equity side of the house, we need to figure out how do we seed and fund entrepreneurs that want to do work in this space amongst the populations that we just mentioned in the lexicon. How do we look at the digital divide and continue to make sure that we're doing work in that area to make sure that folks have access to broadband, in bringing all these stakeholders together to have that dialogue to make sure that we're advancing policy, insights, and thought leadership to move the needle in the right direction. So that's a little bit about the work that we're doing and continue to do. And we would love to partner with anyone that shares our mission and values in this area.
Great. Thank you, Michael. As we get ready for audience Q&A, Jen, I'll turn to you to kind of wrap it up for our panel portion. DIME's work has been instrumental in laying the foundation for digital medicine that is ethical, effective, equitable, and safe. Healthcare and life science leaders look to us for resources to support and help accelerate their initiatives. How can the industry demonstrate that health equity is a top priority? Looping back to the beginning where we talked about moving from talking to taking action. How is DIME supporting with our current and future work, future programs for health equity?
It's such a great question, and there's a good conversation going on in the chat as well about sort of what's the drivers here, and this notion of sort of a double bottom line. Something that Yashoda, you and I talk about a lot as we build our sort of DE&I activities even further. Michael, this is something you and I have also spoken about as well, is what does industry need to do? We need to start asking different questions. The sort of source of consternation for me is, oh gosh, should we drive forward with this digital innovation? What will it do to health equity? And it's incredibly frustrating. Take a look around. The state of health equity is about as bad as it could possibly be. Instead of sort of wringing our hands and wondering whether we should advance innovation that improve access, that could reduce the burden of disease for particular communities, that could make healthcare affordable for individuals and society, what we need to start asking is, how can we use the digitization of healthcare to make sure that we are caring for everyone in ways that are equitable? How can we make sure that there is not a sort of poorly distributed disease burden across different communities? And the work that we have done at DIME and the work that we continue to do in collaboration with all of the speakers today is to actually say, we are going to help you answer that question when you ask it. When you are making your investments in digital strategies, when you are going after your sort of bottom line, we can make sure that we bring everyone with you, and this is how you do it. None of this is an unsolvable problem, and that's the thing that's most frustrating, but it's also what's most compelling. We have to keep pushing. We have to keep, working closely with our industry colleagues to reframe the question. And when the right question is asked, we have to be standing there with solutions. Those have to come from the community broadly. And I think that's the call to action for all of us today.
Thank you, Jen. So I invite our audience, if you have any questions, feel free to raise your hand and we'll ask you to come on and ask your question live if you're in a place that allows you to do that. If not, please put it in the chat and we will ask it for you. I do have a question for Michael. It's phrased more like a statement, but I'll read it to you. You said, start with a health equity plan, then build your DE&I plan. We're just shortening that for time's sake. I want to know more. So can you expand on that for us?
It depends on your organization, but a number of organizations have developed a DEI plan first, right? So they have a DEI plan. Now they are tackling health equity as a theoretical construct, right? Some folks didn't have a DEI or a health equity plan, depending on the organization. And so now they are tackling health equity, but they haven't fully appreciated the contribution and the impact of having a comprehensive DEI strategy. So it depends on where you're at in terms of your maturation of an organization. And if you are creating a health equity plan and do not have a DEI, you need to really think through what are your populations that you're serving from a health equity perspective. What are those outcomes that you're seeing in terms of healthcare disparities? What are some of those contributing factors, those social determinants of health? And then do I have the data and analytics infrastructure to be able to analyze, understand the problem in which I'm trying to solve? And then from a stakeholder perspective, do I have the relationships with the key stakeholders that I need to be able to effectuate a strategy that is inclusive, comprehensive to solve the problem? So that's how I kind of think about it. And digital health plays a role because it increases access within your target population and allows you to have a heightened level of engagement that you didn't have previously, right? So now with these digital tools, we actually can have ongoing engagement with our target population. That wasn't something that was actually possible previously. So that's how I think about the framing of that.
Thank you. I'm not seeing any hands, so I have another question. This one is for Jen, and it has to do with the popular kid in town right now, which is AI. So Jen, you were recently named to the board of directors for the Coalition for Health AI, and part of CHAI's mission is to be a trusted source for standards for responsible AI in healthcare that serves everyone. How the majority of data supporting AI right now are built on homogeneous data. How can we use those data, those AI systems, knowing that but still be able to move forward in a relevant way to include more diverse populations?
A big question with 2 minutes to go. So happy to dive in on this one. I think, you know, in its simplest form, it's a yes and strategy, right? And this gets back to, are we going to sit here wringing our hands in consternation? I think what we've got to do is get moving with the data that we have. And I think we need to be eyes wide open to the limitations of that data. We need to do everything we can statistically and with our data science and with our interpretations to correctly evaluate what we have. Meanwhile, we have to simultaneously hit the gas on collecting data. And I would put the sort of data piece almost into 2 phases, which is the data collection, the actual identification of the data elements that we need in order to build and evaluate models that we can trust. That gets back even to some of the lexicon discussions that we've been having today. And then there's a secondary piece, which is even if the data exists, you then have to sort of acquire it. You have to be able to push it into your model, and you have to do that in a way that is, you know, secure for the originator, but also that is, you know, respecting individuals' sort of data rights and their privacy and all of these different sorts of things. So I think it has to be a 2-step approach. We need to get moving, and we need to use all of the statistical and data science techniques at our fingertips in order to make the data we have as useful as possible, as well as refraining from making inferences about the models we have to work in different settings and populations. Simultaneously, we can't just stand by and admire the problem of unrepresentative and insufficient data. We have to act on that as a priority.
Thank you. We are almost at time, and so I want to say thank you so very much to our panelists. We have so much content. We can have a whole series of conversations on this, and hopefully we can do that soon. To everyone, I would like to leave you with the invitation to check out the Dimensions of Diversity lexicon. Print it out, keep it by your desk, consult it often. There's so much information, and it gets us to start building credibility. To Michael's points earlier, representation matters. Everyone wants to know that they're included, and this is one quick and easy way you can start to do that. I also want to invite you to join us again in April. We have a very busy month with several activities. On April 10th, we have the Physical Activity Industry Days, and you can use this QR code or come back to DIME's website to learn more about that. On April 18th, we have Clinical Trial Efficiency using data and digital health tech. And again, you can register from the DIME webpage. And then on April 24th, we have Advancing Sleep Research, New Core Digital Measures and Resources. So there's always something for everyone at DIME. And thank you all for sharing. And we look forward to seeing you at our next webinar or journal club. And thank you so much again to our panelists for making this such a rich discussion. And we would love to speak to you again and continue making small but meaningful efforts in advancing health equity. Thank you, everyone.